You have discussion. No, that's, yeah,
I know it. Good morning, everyone, and welcome to the Monday morning grand rounds. We have a very high-tech, interactive program this morning that involves Dr. Roman Melamed, Dr. Paul Odenbach, Dr. Alex Campbell, Dr. Ben Sun, and Dr. Bjorn Engstrom. So we have a very fun program. The discussant this morning will be Dr. Roman Melamed, who I think all of you know. He is the Director of Research for Critical Care Medicine here. Roman's one of the few people I know that moved to Minnesota to get warmer. He is from St. Petersburg, where he did his early training, and then he did his residency here at Abbott and his critical care fellowship over at Hennepin County Medical Center, and has assembled the pulmonary embolism response team here at this hospital, which is very elegantly done for the past several years. Paul Odenbach is known to many of you, all of you I think, as one of our exceptional hospitalists. Paul's also a product of this institution, did his training here and has been here since 2002. He is the inspiration for this morning's talk, as you will see from the first case that he's going to present. Alex Campbell is going to review the echoes as we go, and then at the end we'll have a discussion, starting with Ben Sun and Bjorn Engstrom. So welcome all. Dr. Odenbach, you are up. On deck is Roman Melamed.
I got this one. Thanks. So this first case, it was a pretty striking case of a 58-year-old who, interestingly, had been being treated for a glioblastoma. He was getting intraarterial carbo and IV Avastin, has some other medical problems, as you can see. He really had about a week of fatigue, 3 days of cough, and interestingly, kind of this, what ended up being a red herring sore throat. He ended up going to a urgent care, getting some amoxicillin, really didn't get better, more short of breath, and family said, you know, he's had kind of this right lower extremity clot, well, what looked like clot or swelling to them over the last couple weeks. You know, you can see his vital signs there, not very decompensated, but a little tachycardic, a little tachypnic, on a couple liters of oxygen, but looked relatively in not a lot of distress. You can kind of just review, of course, the D-dimer is sky high, BNP kind of moderately elevated, chest x-ray is normal, as Doppler shows a lot of clot in his right leg. So, of course, he goes to a CT pulmonary angiogram, and I'll show just kind of an illustrative picture on the next slide that shows extensive PE with saddle pulmonary embolus, as well as what was called right heart strain on the CT. There was a discussion given his status of the glioblastoma and the fact he's on IV Avastin and getting intraarterial carbo, and felt that he wasn't a TPA candidate. So he was just started on IV therapeutic heparin. But the clot burden in this fellow is quite large, pretty impressive. And the next step that was done emergently was an echo to get an idea of what his RV and what his heart looks like. So maybe Alex can enlighten us on this.
So the left ventricle is hyperdynamic, probably underfilled. The right ventricle is very large. In the literature, usually if the right ventricle is greater than the left ventricular size, that's considered significant RV enlargement for research. And then you see the RV apex is hyperdynamic and the RV free wall is akinetic. That's called McConnell's sign. There's a few different proposed mechanisms, if it's tethering from the LV, if it's ischemia of the RV free wall, or it's the bullet shape of the RV, but it's a enlarged RV with severely reduced function.
Okay. So the thought at this point was, gee, this guy's RV looks pretty bad. Clinically, he's doing okay, although he's on a couple liters of oxygen. He, you know, of course, has a large amount of clot in his right leg, so at least they want to put a filter in. But because he's not felt to be a TPA candidate, they say, why don't we talk to Dr. Ehrenwald, who happened to be on that night for Dr. Engstrom's group, try to do a suction thrombectomy. You know, his pressures really didn't change much. Ed thought that there was kind of a reasonable angiographic results, but he did notice this free-floating thrombus in the left main pulmonary artery, which he was unable to remove. Filter was placed, and he was sent up to the ICU on therapeutic heparin. The next morning, he has this echo to kind of check again what his heart looks like after suction thrombectomy.
Really unchanged. RV's still.
So at this point, I get a call from Dr. Melamed's service, the intensivist, saying, here's the story on this guy. They review everything about him. He's going to come to the floor as a kind of what we call an ICU pickup on our service. He's leaving the ICU. Our service is going to take over. Reviewing the images and especially this kind of follow-up echo, it felt maybe like we could entertain possibly having our surgical colleagues review the images to think about, would we ever bring this fellow to a surgical thrombectomy? Part of that was, again, really no change on the echo. It looked just as bad as before. I felt like we were a little bit falsely reassured by doing something that night with the surgical thrombectomy, but essentially this guy is the same as when he came in, except with an IVC filter and on heparin. And I talked to the nurse about how he's doing, and she says, well, I kind of got him up on the bedside, and he started to get lightheaded and felt like he was going to pass out. And, this guy was going to go over to Telly and start walking the floors. I was a little bit hesitant, which was a clinical piece that maybe just a little bit more suspicious for something more to do, perhaps. Of course, given the fellow's history of a glioblastoma and how he was functionally doing, we wanted to take that into consideration before proceeding. But I did end up talking with Dr. Sun, who reviewed the case, and he did go to surgical thrombectomy. He arrested in the OR right after he had induction, a couple minutes of CPR, but he recovered once he went on pump. And he had just an incredible amount of thrombus taken out by Ben in the OR, which is graphically described or displayed here. So I was rounding later that morning and got this text from Ben with this picture. So this is what I got from this guy. So post-op day 2, unfortunately, had a brachial artery hematoma, needed a lot of packed cells that was from an art line that had been placed, but that got better. I've got a follow-up echo, which is kind of gratifying, which actually shows normalization of his RV about a week later. He ended up going home on Lovenox with his filter in place, and he's still living at home, still getting his intraarterial chemo and his IV Avastin. And here's his follow-up echo about 1 week after the surgical thrombectomy. So I don't know if you want to,
Looks normal.
Great. So that's case 1. So Roman is up.
All right. Just on the belt. All right. Sorry. Of course, a complicated topic. So the hope is that we'll go quickly through some background info and a couple more cases and then have a discussion. So we've looked at some literature on surgical embolectomy. It doesn't, it is probably not complete, but this is what we found on PubMed. Mostly case series or case report. I kind of made a table out of 4 case series that were published within the last 10 years or so. Mostly, the number of cases is not large, and these are centers that do the surgical thrombectomies routinely. The patient population, a lot of patients who present either in cardiac arrest or shock with severe RV dysfunction. Many patients have contraindication to thrombolysis. The mortality, 12, 8, 19%. Hospital course, typical complications, stroke, some infections. But the outcome, people who do survive the operation and go home, they have good outcomes. In this case series, 11 of 15 survivors had a very good functional outcome.
87%, 5-year survival, RV improvement in pulmonary artery pressures. I made a separate slide of this study. I think this is the largest one. As you probably know, Brigham and Women's Hospital has surgical embolectomy on their protocol for massive, but also for selected cases of submassive PE. So they report their experience over 14 years, 115 patients, 10 were excluded because they didn't have a PE. About half of these patients were stable, i.e. submassive PE, so they did not have obvious hypotension or shock. Their indications were about half of the population, contraindication to thrombolysis, minority failed thrombolysis, hemodynamic instability. But again, about half had RV dysfunction alone, and the decision was made to go to surgery. Their overall OR mortality was about 7%, and for massive was 10%, for submassive 3.6%. 1-year mortality also, so if you have a massive PE, obviously the outcomes are worse than submassive. And but the long-term survival, pretty good. This is a study using the nationwide inpatient sample. So this is more administrative data, and so it's a little more difficult to interpret, but they show that there's a good number of cases done on surgical embolectomies, and in stable patients, I can't tell what they call stable, probably not hypotension or shock. The mortality was about 24%. And in general, the indications for surgery, 74% hemodynamic instability, about a third cardiac arrest, and contraindication to lytics. So this is the big picture as far as we know in terms of surgical embolectomy in this country. And having said that, we will look at case number 2. So this case I saw, this is a year and a half ago, I think. It's a 39-year-old female who presented with shortness of breath and abdominal pain. She had a CT on admission, a CT chest, abdomen, pelvis that showed fairly extensive pulmonary embolism, mostly in the right main pulmonary artery. And also, she had a very enlarged uterus and large left adnexal mass that we thought at that point was probably cancer, but we didn't know for sure. She didn't have any medical care prior to. Alex?
Again, same, very large right ventricle on top and underfilled hyperdynamic left ventricle.
What's that?
In there. Actually, a clot in the right atrium. You can see traversing the septum through to the left atrium. Probably through a PFO.
All right. How about this?
So PE, on the left side there, our left, is the right atrium, and then you can see the clot traversing the septum, the atrial septum, right behind the aortic valve. So it's through a PFO, a very large clot. It's a nice 3D picture. Same thing, so 3D picture of the large clot traversing the septum.
So she was actually admitted to telemetry. We were consulted. It looked pretty worrisome. At that point, we didn't really, I really didn't know a whole lot about this type of a clot. So we consulted cardiology, as we always do. And Dr. Palouse came in, and he looked at the echoes, and within 15 minutes, he had a decision. He called Dr. Flavin, and probably within the next few hours, she was in the operating room and had a surgical embolectomy. So this is the description from the OR report: evacuation of thrombus across the patent foramina valley, left atrium, closure of patent foramina valley, 15-centimeter organized thrombus removed from IVC just below the diaphragm. they were unable to retrieve much of a clot from the pulmonary arteries, and then they were not able to take her of the cardiopulmonary bypass, and she was placed on ECMO. This is a post-op echo.
So severe biventricular dysfunction, LV and RV severely dysfunctional.
Not sure, prior to surgery, her LV looked okay, but the hospital, of course, she also had an IVC filter placed because she had an extensive DVT. She was attenuated on day 6 and remained hemodynamically okay. Then she went back to the operating room. She had some hematoma. And this is day 18.
LV is recovered, right ventricle still decreased function, at least moderately.
And this is 6 months post.
Much better.
So it's essentially RV normal. Follow-up, she's alive. She lives at home. So she actually had a popliteal fossa liposarcoma projection. So she did have cancer, but not the OBGYN cancer. And then she was treated with radiation. I think she went to the university for this. And then she came back here at Abbott and had a hysterectomy and self-oophorectomy. Yeah, there was no malignancy. It was all benign. Actually, she had a DVT during her second hospitalization because she was taking all the anticoagulation for the operation. But at that time, she didn't have a TE, and she was just placed on, I think, Lovenox, and did fairly well. So after this, we started looking at literature on this type of a clot, and it turned out that also not a lot of studies on the free-floating clots in the right heart, mostly case series and case reports. So this study comes from France, and this is pretty much the biggest case series that I could find, 38 patients they described. Overall, pretty sick patient population. Class 4 dyspnea in most of this cohort, and shock 52%, cardiac arrest 47%. So this is a very sick patient population. Their in-hospital mortality was 44%, and the first-day mortality was 21%. So that's how sick these people are. This is their, they just described, it's completely, obviously, observational. So this is how these patients were treated, and the treatment was up to the primary team. So 17 patients had a surgical procedure, 47% mortality. In some cases, it was a rescue surgery, so people were already in kind of arrest or a profound shock case. Thrombolysis, 9 patients, and for the most part did well. Some patients were just heparinized. But this, if I remember the details, they didn't really do very well because they require either a rescue, catheter-directed intervention, or TPA or surgery. In 4 cases, 4 patients were treated with interventional techniques. So this is the mortality. And actually, a few years ago, the New England Journal of Medicine published a case very similar to ours from Mass General Hospital that they had. You want to comment on this picture?
Like ours are better. It's the same thing. It's a thrombus traversing the septum from the right atrium to the left atrium through a PFO.
So a case very similar to ours, 60-year-old who presented with syncope. And they go over their kind of decision-making why they chose one treatment over another. They were thinking about catheter-directed intervention, were concerned about fragmentation, systemic embolization. They were not comfortable using systemic TPA due to bleeding complication, risk of bleeding complications. So they chose a surgical thrombectomy. The patient did very well and was discharged home in very stable condition. So, and then case number 3. This is a 73-year-old male who is admitted with elevated troponin, shortness of breath, and lower extremity edema. History of atrial fibrillation, renal insufficiency, and hypertension. And this is his echo.
Again, normal LV function, severe RV dysfunction, RV is very enlarged.
Okay. So he was treated with for congestive heart failure, and actually Dr. Sharkey was his attending cardiologist. But on day 3, he had more shortness of breath, and they were thinking about sending him home. But then they didn't because he wasn't feeling well, needed more oxygen, and they had a CT scan obtained, and am I correct that bilateral pulmonary emboli in both left main and right main pulmonary arteries? Yeah. So big PE, another cut here, mostly on the right side, so you can see a big clot here. And this is the echo. There's something in
Thrombus in the right ventricle or something. Yeah. That's coming from the inferior vena cava into the RA.
So another.
Like shown in the pulmonary artery. You can see the thrombus.
All right. So in this case, the team decided to go with IV TPA. And Dr. Sharkey, was there a big discussion or it was just decision?
Well, what happened was I saw the guy, the patient on Friday night, and we figured out that there was a pulmonary embolism, but I ordered the echo for the next day, Saturday, and Dan Melby was the consulting cardiologist that decided to give IV TPA, and it was a very good decision as far as I'm concerned.
All right. So this is an echo about 4 or 5 hours after the TPA.
There's resolution. There's no longer any echogenic material inside the heart. And the RV function looks better, a lot better.
He also had an IVC filter placed and discharged home on heparin. Did well. So these are the cases. Now I'll have a few slides to just give you a little background for the discussion. And we all know about the guidelines, and we're not going to go into much detail. They're here for the record, and you're welcome to go back, look at them. In general, there are 3 sets of major guidelines: American College of Chest Physicians, American Heart Association, and European Society of Cardiology. In general, with some variations, they say that if you have a massive PE, i.e. hypertension or shock, treatment with systemic TPA is the recommended treatment. It's the first-line treatment. If you can't give TPA for whatever reason, contraindications or some other, then you have catheter-directed intervention or surgical embolectomy. So that's the bottom line. The difficulty is that in addition to the obviously unstable patients, there is this subgroup of patients who don't have hypotension but still look very sick. They have severe RV dysfunction, positive troponin, positive BNP, and it's hard to know what to do with them. And the guidelines, for example, this is an example of ACCP guidelines. So they say in selected patients with acute PE who deteriorate after anticoagulation therapy but don't have hypotension, consider systemic thrombolytic. And then it goes, this is a statement, it's a very diplomatic statement that says that, well, the patient may not be hypotensive or in shock, but could have some other things, such as tissue perfusion abnormalities, gas exchange, cardiac biomarkers, that you also want to consider for more aggressive treatments. And this is where, on our medical side, this is where the difficulty is, how to select this subgroup of patients who are still not hypotensive, but sick enough to require a treatment more than anticoagulation. Pretty much the same with the American Heart Association. And actually, this is a fairly new set of guidelines from the European Society of Cardiology. They don't use terms massive, submassive PE. Now they use term high risk, intermediate risk, and low risk PE. And the low risk PE is a stable PE that requires only anticoagulation. High risk is a hypotension and shock. Intermediate, they divide in intermediate high, intermediate low. based on the RV function and cardiac biomarkers, i.e. troponin and BNP. They also use a pulmonary embolism severity index, which is still a topic of discussion. But in general, they do recommend surgical pulmonary embolectomy if thrombolysis is contraindicated. This is for patients in shock, and in general, when they describe the reperfusion therapy, they say that it could be considered in intermediate high-risk patients if anticipated risk of bleeding under thrombolytic treatment is high. So there's a little bit of a mention for this high-risk submassive PE group that may also benefit from surgical embolectomy in specific cases. A few studies that I think might help with the discussion. So we know this is just to illustrate who actually dies from PE and who doesn't. The patient is hemodynamically stable, doing well, looking good, the mortality is very low. If the patient is in shock or cardiac arrest, the mortality is very high. This is the gray area, and this is the difficulty that most of our patients in the ICU are in the gray box, that, you know, they're sick but not sick enough to call them shock or hypotension, and the mortality goes up the sicker they are. In terms of the size of the clot, of course, size of the clot matters because it affects the heart and the hemodynamic picture. But in general, this is a nice study that looked at a variety of papers in patients with anatomically massive PE, so large clots, bilateral pulmonary arteries, or settled emboli. And what it shows that if the patient has shock, the mortality is high. If the patient with the same massively appearing PE doesn't have shock, the mortality is low. So it isn't just the size and how it looks, it's how the patient looks too. And this is our patient from a couple of weeks ago that I think Dr. Lawler was on the phone with me for the PE response team, and Dr. Sharkey was part of the treatment team. This was an 82-year-old patient who was admitted with shortness of breath, tachycardia, positive tropes, and BNP. And this is his CT. It's a saddle embolus, obviously bilateral. We gave him 50 milligram of CPA and systemic anticoagulation, and he is stabilized and went home on day 4. So this is another nice study that looked retrospectively at almost 700 patients with pulmonary emboli, and about 5% had a settled embolism. For the most part, people did well, and the mortality was 5%. Most patients were treated with systemic anticoagulation. Some of them got TPA. So in general, the size, it's not just the size, it's what the patient looks like. A couple of studies that we definitely need to know about because it affects our treatment algorithm at Abbott and what we do and what we struggle with. So this is the PISA study that was published in 2014. This is a large multi-center randomized controlled European study that looked at fairly stable submassive PE population and they looked fibrinolysis versus just anticoagulation. Their definition of intermediate PE was RV dysfunction plus positive troponin. And what they found that treatment with thrombolysis was beneficial in terms of the primary outcome. It was significant, basically because it prevented hemodynamic decompensation, which we already know about from previous studies. Unfortunately, there was a lot of bleeding. There was a major bleeding, and there was 2% hemorrhagic stroke. So based on this study, of course, people got very concerned that, yes, the outcomes may be better, but you just can't afford having that much bleeding. This is the follow-up study that was published just a few months ago in JACC on the same PISA study. And I just wanted to point out their patient population. This is their average blood pressure. It's hard for us to even imagine to take someone to give TPA or do something more invasive with a blood pressure of 130. So this was a fairly stable patient population. Of course, there were sick people. And this is what they found, that in general, the mortality was not affected by use of the systemic TPA versus systemic anticoagulation. And the development of chronic thromboembolic pulmonary hypertension was pretty low, 2% versus 3%, of course not significant. So in general, if you look at big outcomes, the thrombolysis in long-term in this study did not give a lot of additional benefit. This is a graph from another study that was published a few years earlier, also in the New England Journal of Medicine. So about 3 to 4% of patients with PE develop chronic thromboembolic pulmonary hypertension, and usually by year 3, they will develop. If they were to develop, it will show. So this is what studies that we kind of try to base our decisions on how to approach this patient population based on. So because of this risk of bleeding, we looked at the studies of that investigated reduced dose TPA. In general, systemic TPA is given in the IV, so theoretically it should get into the right heart very quickly in a full dose, right? So there is a study that published in 2010 in chest. This study comes from China, and they looked at about 120 patients randomized to 50 milligram versus 100 milligram IV TPA. 100 milligram is FDA-approved dose. And what they found that the outcomes were the same, and their outcomes were mostly imaging outcomes: resolution of clot, improvement of perfusion on VQ scans, and so forth. But what they did find that in smaller patients, lighter patients with lower BMIs and weight less than 65 or BMI less than 25, there was decrease in the rate of hemorrhage with reduced dose TPA. Our patient population, BMI less than 25 is not very common, at least in this hospital. We did another study, and our average BMI was like 31. But in general, it makes sense. Smaller patients, lower blood volume, so you get more TPA. So this was a little bit of an encouragement for us to consider lower dose TPA. And then the MOPETT study, this came from, I think, Arizona. They actually randomized patients to 50 milligram of TPA plus anticoagulation versus anticoagulation alone. They found that the incidence of pulmonary hypertension was lower, and their bleeding risk, they reported as 0. It's hard to imagine 0 bleeding, but this is what they reported, and we looked at the study very carefully. It wasn't an ideal protocol, but we decided that maybe we should use their experience and use their protocol in our patients if we decided to give TPA. So in the last 5 minutes, I'll show you what we did here at Abbott with the PE program and our protocol. So this was a multidisciplinary effort with active involvement of our cardiology colleagues and pulmonary interventional radiology. So this was really fun work to do. So we developed this protocol. It's work in progress all the time. We change it all the time because, you know, new data comes out and, you know, we get new ideas. We also participate in the National PE Consortium, and they also work on their protocol. So we try to at least stay close to the National PE Consortium. Is based, hosted by Mass General, but there are about 80 centers that participate now. So this is the protocol. So any physician based at Abbott can call 31000 one-call transfer center and activate the PE team. You get a cardiologist, intensivist, and interventional radiologist on a conference call, and they can discuss the case. For the most part, it's a hospitalist or ED that initiates the call, but we got some calls when the patients were at the outside hospital. Some calls came from cardiology or intensivists. And so we obviously we have submassive PE, and for stable patients with no risk features, we recommend anticoagulation. For massive PE, shock or hypotension, we want people to consider surgical CV surgery consult and consider mechanical support early. So it's in the plan. And then we recommend either systemic thrombolysis or more invasive interventions based on the risk factors and specific situation. For the submassive with high-risk features, which is a moderate to severe RV dysfunction, worsening hemodynamic status, elevated TROP or BNP, and we use this SPACI score kind of mostly for FYI to be considered either systemic TPA or catheter-directed interventions if all the risk features are present, and the patient is a candidate, and depending on the bleeding risk factors. The back side of this protocol, by the way, you will have it on your app, so you can look at it. It's also on the AKN, on the intensive web page. If the provider decided to administer TPA, then we have a checklist, so you don't need to search in the middle of the night, search up to date and make sure that everything checked out. We have some examples of the regimens and description of the catheter-directed interventions. If providers decide to use systemic TPA, there is an order set that kind of guides you through the dosing regimens and some labs that we would like to follow. In general, the PE response team, the concept is that it's a multiple steps and involves the referring service, so people who call this one call center, which are mostly ED hospitalists and other services, know how to call, how to activate the team and what to ask for. The PE response team, and we also work on the follow-up, and we've been working with Dr. Ekman and his group to send patients who have residual RV dysfunction, pulmonary hypertension, to the PE clinic so they get appropriate follow-up, appropriate coagulation studies, and so forth. Two last slides, and then we'll have a discussion. So these are our results for 2016. So the PE team was launched in January of 2016. By the way, this was Dr. Engstrom's idea to start with. He wrote those papers from Mass General and said, why can't we have it here at Abbott? And we said, well, yeah, we should. And then with the help of Dr. Campbell, Dr. Harris, Dr. Samara, and others, it is happening so far. We're trying to maintain it. So just FYI, at Abbott in 2016, we had 353 PE patients with a PE as a primary or secondary diagnosis. So our patient population is pretty big. About 10% ended in the ICU, and about 10%, a little bit more than 10% went through the PE response team. So we don't want a phone call on every PE patient because we just don't have resources, and we don't need to know about every PE patient, but we want to know about sick people. So there are 50 PE team activations in 2016 on 45 patients. So some patients had the PE team activated twice. For the most part, it was the hospitalist or the ED who activated the team. The patients came from telemetry floors, very typical, from the ED, from outside hospitals. Some were already in the ICU. Most PEs were qualified as submassive, so they did not have hypotension or shock, but were sick enough to make their providers concerned. One patient actually didn't have a PE. We figured it out with the help of our radiology colleagues. For the most part, the RV dysfunction was described as moderate or severe. I don't have the TAPSE numbers here because when I was collecting this data, I didn't know how to get them out of the F report. Now I think we know. Actually, 22 patients had about half had a follow-up echo, and in 20 cases, the RV function improved, no matter what we did. The follow-up range was from 1 day to 4 months. 21 patients were treated with anticoagulation alone. 19 patients received systemic TPA. A total at Abbott, 26 patients were treated with TPA. Some of them didn't go through the PE response team. The provider just decided to do it, which is, of course, totally fine. The majority of patients received reduced dose, 50 milligram. Some patients received 100 milligram. You see the trend that if the patient goes through the PE response team, the chances are they'll get the reduced dose TPA. if they don't, and I think it's probably a function of how sick the patient is. The provider probably doesn't have time to assemble the PE team. Some of them were cardiac arrest. We have 7 catheter-directed interventions, and what I know about is 4 surgical embolectomies from September 2015 to now. So we had 1 in September 2015, 2 in September 2016, and 1 in January 2017. In some cases, we just say, we don't need the patient in the ICU. The patient is stable. We just give an advice like more PE team consult to a provider. 3 deaths among the patients who went through the PE team. 2 were cardiac arrest. 1 was death from unrelated to the PE cause. And we had 1 hemorrhage. It wasn't a major hemorrhage, but it was enough. It was a retroperitoneal. It was after 100 milligrams of TPA in a patient who already had an right femoral stent for intervention. So, so this is what we know, and we'll open for discussion.
First, let Dr. Sun and Dr. Engstrom, and then we'll open it up for general discussion.
So, you know, there's a mystery of pulmonary embolisms from a surgical intervention because people confuse acute pulmonary embolectomy with chronic thromboembolectomy procedures, which is a totally different operation. The chronic for the CTEPs are basically it's endarterectomy, pulmonary endarterectomy, which is a big operation done on circulatory arrest, similar to what you do with carotid endarterectomy. You're peeling off thick layers of organized fibrous tissue from the lung parenchyma going out. That's a totally different animal from acute pulmonary embolectomies, which are it's like picking your nose. It's about as easy an operation as we can do but they're like anything else. There are tricks to it, and if you understand the tricks, it's one of the easier things that we do. The challenge is that not a lot of surgeons, because you can see the experience, have even seen it before. But I can just tell you, you know, on a scale of 1 to 10 for what we do technically as surgeons, this is a 1. I mean, this is like practically closing a PFO. It's really easy. Now, so that's sort of the challenge of where we are in the continuum of therapy. For those of us who have done them, and I've been doing them for probably 15 years, you rarely lose anybody from this. The ones that you lose are the ones that we've gotten too late. And if you look at it, the data that you've seen up there, a lot of them that you have your failed surgical ones are people who, you know, we do the operation, but we've had anoxic brain injury. In fact, that was one of my deaths this year. Was we just, you know, the person had CPR from the ED to the cath lab, thrown on ECMO, went to the OR, fixed it, never woke up. Turn them off 2 days later. The heart was fine. So that's still a failure of surgery, but it's not. But that's the nature of the beast. So unfortunately, we end up kind of relegated to a little bit of a niche component of this therapy, where I think in reality we could have a higher benefit for those who are even in the marginal area. That's my opinion. The CTEP data, which is coming out, which we're starting to understand, we don't really know the long-term effects of thrombolysis and anticoagulation in what the incidence of that is, and we're starting to get some data that it seems to be lower than some of us thought. The older data was that it can be as high as 10% of people who were treated with regular heparin, but again, you need large studies as they're starting to follow through to see how many of these patients convert from, you know, a stable early to a late. The data shows that after 3 to 6 months, some of these people will develop it, some of them don't, but we don't know that true incidence. Of those who have surgery for CTEP, and there's only a few sites that do that very well, it was pioneered in UC San Diego, you know, virtually all of them, or 80% of them, are from previous pulmonary embolisms. So if we can avoid that, the clot burden from some of these is probably a good thing, especially if we actually, like anything else, the earlier you get people, the better they do. I mean, we see that in every therapy that we have. So if surgery is only relegated to failures, it's kind of what you get.
Was it unusual that one patient that was referred for embolectomy surgical, that there was no thrombus in treatment? I don't know which one that was.
This was
PFO. From the PFO, but how did he wasn't thrombus? Okay. So there was nothing in the So then I've got a question for you. Are you comfortable doing the decapitation here?
No, that's a big operation. I've never done it, and I don't know. Yeah, it's a big deal. I mean, I've just seen it, but I've never. I don't know any of us have done it. It's a really specialized procedure. Yeah. So the question was whether or not we do CTEPH here. Like I said, I haven't done it. I don't know if any of our partners have ever done it before. It's a very specialized procedure.
So first of all, I just want to congratulate you guys on a really great conference and a good topic. And then second, I wanted to say, thank you to Dr. Melamed, because all the work he's put into this PA responsive is he's done a lot of work, and it's really turning into something great, I think, for everybody, because this is not a straightforward topic. Clearly, there are a lot of specialties involved, and it's very complex, and we still don't know the answers from all the literature we have. And so to have all these specialties come together and talk on the phone to help facilitate the treatment is really, really helpful for everybody, I think, and definitely for the patient. So that's really great. Thank you, Roman.
I would totally second that from the hospitalist standpoint. In the dark ages, we were getting these patients on the floor, and it's middle of the night, and you're alone looking at this, deciding, who do I call? And now it's a nice protocolized, let's get a bunch of brains together, and you feel like we've got a team to kind of manage that. So again, thanks to everybody for that.
The other thing is, in terms of the interventional radiology treatments for this, I know that's a huge expanding area in the country. Well, it's done by interventional cardiology too in a lot of areas. So it's an exciting time, and we still don't have a lot of the answers. Just briefly to how we manage these here at Abbott, we kind of break it up into massive and submassive. Clearly, you have to do more urgent treatment for massive, where you can actively fragment and give TPA at the same time. Whereas for catheter-directed, we do very ultra-low dose TPA infused at 0.5 or 1 milligram an hour over 12 to 24 hours. And we've chosen as part of our protocol to do that in patients that are at higher risk for bleeding, because we felt, and in the data, we don't have the data for this yet, but we felt that the half-dose lytics in submassive patients work well. But if they're high risk, such as high age, we look at scores to determine if they're higher risk or not. And in those patients, we figured if we give 12 to 24 milligrams of TPA over 12 to 24 hours, then that should be safer. And so far, we've had good outcomes with that. But.
And just for questions, I've got both mics going back and forth, so just please wait for an answer, and then I'll get you another mic. Dr. Harris first.
Well, Roman, also my congratulations on your hard work, put all this together, and fantastic talk, so thanks so much. I think, like Paul said, it's really not a condition that anybody encounters a lot, so that to have evidence-based protocols really makes a difference, and then you can kind of rely on your colleagues for help from their aspects. So that's what I think makes it really good. Just a couple comments. First, as far as the follow-up, we can probably talk about how do we get all of those patients with RV dysfunction or pulmonary hypertension back for follow-up. And then secondly, to me, the difference between case 2 and case 3 was the fact that the thrombus crossed the septum between the two cases. And I doubt there's much in the literature, but if you have any thoughts on what is in the literature on the clot in transit versus case 3, which was where it was isolated to the right side. And I would think in those cases we'd want to have a really good look at the patent foramen or the foramen to make sure there is no PFO.
All right. Thank you so much. It's a beautiful talk, and congratulations to Roman and the rest of the team for the great work as well. I just want to say a comment and then maybe a question. So I also been, part of the follow-up. Sometimes if those patients follow on me in the clinic on the thermophile anticoagulation, I could see how difficult the decision-making can be. It's been a pleasure to be part of that work at the end, if you will. And so based on the 3 cases received IVC filter, and despite that they were able to get anticoagulation, based on the PREPIC-1 trial that showed, looking at patients that received IVC filter versus patients that did not receive IVC filter, those patients that received IVC filter had less PE, but the mortality was not really changed. And yet also those patients had more lower extremity DVT. And the PREPIC-2 trial showed those patients that can be anticoagulated and you randomized to receive filter versus not receive filter. There was, again, no change in mortality. That's why the ACCP guidelines, as you know, as you listed in your slides, say that if the patient can be anticoagulated, should not actually receive IVC filter. So this discussion comes all the time, where we go with IVC filter. So those 3 patients received IVC filters. What happened after that? Were they retrieved? Did they really need the IVC filter if they were able to be anticoagulated? I know that they had massive PE and they had lower extremity DVT. Maybe Bjorn can help me to certify this.
Yeah, that's a good question. The PREPIC-2, as you mentioned, has tons of flaws, obviously, that we know of. The one thing was a third of the patients had superficial venous thrombosis. That I can't think of anybody that in their right mind would ever put an IVC filter for that. And then they had to place a filter within 72 hours, which I don't know how somebody would get a call on Friday and say, well, it's kind of late on Friday, let's put it in on Monday. And maybe that's why 2 patients died in that small study population. So because it was intention to treat, I'm not surprised that it was a negative trial from that perspective. But clearly, I think that and other data suggest that you can't just indiscriminately put in IVC filters for somebody with submassive PE. And so that's one of the discussions we have a lot on the in the conference call, and that's also very helpful, I think, for the hospitalist and whoever makes the call. But so I think we look at that very carefully, look at the clot burden in the lower extremities, and we look at their current status of if they're able to handle any more clots. But clearly, if they're on anticoagulation full dose, it does stabilize clot. So, and then for the second part, we follow each and every one of our patients that we put in an IVC filter, and we take it out as soon as they're demonstrated to tolerate anticoagulation and have improved from a pulmonary standpoint. So the current recommendation is to remove them 4 to 6 weeks after placement, and that's sort of where you see the most benefit and the least risk, and they're easy to take out. I've taken out filters. Filters have been for years and years, and they just come out very easily. Sometimes you put in a filter, and a few weeks later, they're almost impossible to take out. But we're getting better at that too, and using endoscopic forceps and things like that to pull them out. So usually we are able to get them out, but the timeline is difficult, and it depends on how the filter lands when you put it into the cava. Sometimes they get tilted up against the wall, and then they get endothelialized and grow into the wall, and then it's a lot harder to take out. So it's hard to know exactly from just based on the time.
Roman, do we have any cases of cardiac arrest? That seems to be one of the highest risk populations, and I'm just wondering how the algorithm might work in that specific instance.
Yes. So the cardiac arrest obviously goes into the massive P, and actually we're going to talk a little more about how to put more detail into this patient category. The National P team consortium also works on the algorithm similar to ours, and they have a cardiac arrest in a separate box, and they say go to mechanical support. And this is what we're actually, if you guys are interested in joining the PE team, we have meetings every 2 months. The next one is coming up on the 18th. We'd love to have more brains, and if you have time to go to Boston, June 22nd through 24th for the National PE Consortium, every Abbott employee is admitted for free. We're part of this consortium with paid admission fee. So it would be great to have more than just 1 or 2 people from our institution there, because you get to talk to everyone around the country and pretty much across the ocean to in Europe about the PE thing. Yes, this is something that we will work on, and the algorithm will probably have a little more detail. In terms of the cardiac arrest, unfortunately, the outcomes, once somebody goes into cardiac arrest, the outcomes are not good. We have not had much luck with systemic TPA. We had a patient who went through ECMO, and as Dr. Sun mentioned, surgical embolectomy. We should be a little bit more proactive and kind of get a better sense when the patient is not in a profound shock or cardiac arrest and get on this case and get treatment. So I think we need to strongly consider mechanical support. We need to keep it in mind, and I'm very grateful that Paul picked this case up. And I think it was a little bit of a too early transfer to the telemetry. And yeah, intensivists are perfect, but not always. So we do need other services to know the protocol and to help us, because we do work as a team. It is a PE team.
Just a quick comment too. So we also created a DVT protocols. They're also available on AKN, and we actually refer to your protocols. We call them VT treatment protocols. So the PE protocol is prepared by Dr. Roman, and we prepared the DVT protocols. They're available on AKN as well. And the idea, once we get that app fund going, we're going to have that also, as part of your protocols as well too.
So I just wanted to make a comment with regard to the mechanical circulatory support. Don't think of that just for people that have already had an arrest and are already dead. We had a patient that was actually transferred to us from another hospital in the system that was put on ECMO at that institution somewhat prophylactically. It was one of the first instances I've seen where they actually got verbal consent from the patient. We're going to put you on ECMO now. And the patient was actually awake and able to consent to the decision, and was in the kind of massive category, thought to need a surgical embolectomy, but too unstable for transport, so was put on ECMO, transferred here. I believe that was counted as one of our surgical embolectomies. But for people that are really high risk, it's never a bad idea that you can never talk about ECMO too early. You certainly can start it too early, and you definitely can start it too late. But people do not need to have had a cardiac arrest to be considered for mechanical circulatory support.
Totally agree, but also as we're putting on ECMO, we have to be careful about if there's still clot burden down below, because that would change your approach to the cannulation.
And please thank our supporters. They're outside at the tables. We have BMS this week and Relipsa. So thank you very much. Everybody have a great week.
Thank you. Thank you for coming. Great. Great. You think you'll go to Boston? I think it's 22.